Eugenia, I appreciate the very gracious introduction. When I was training at the University of Michigan in the late 1970s, endoscopic voice surgery consisted of what we called at the time vocal cord stripping and not much else. We have enjoyed delightful progress. I have no conflicts that I think will be active, but I will mention that I make some surgical instruments from which I receive royalties, some of which will be pictured in this talk, but we are certainly not selling instruments. The great advances that we have enjoyed over the last few decades were made possible by our increased understanding of the anatomy and physiology of the voice, particularly the layered structure and the importance of precision that allows us to remove pathology without disturbing subjacent layers and provoking fibroblast proliferation. That is the essence of modern surgery. Surgical decisions are preceded by a much more sophisticated history, physical examination, and laboratory assessment than they used to be years ago, which is important to us not merely in making correct diagnoses, but perhaps more importantly, in allowing us to measure outcomes so that we know when we are doing well and when our surgical treatments need further improvement. With any surgery, the hardest part is selecting the right patients at the right time. All of our surgical patients go through everything non-surgical that might make them better, and they make the decision that it is worth risking getting worse in order to try to get better. When our patients have predictable times when their healing might be impaired, we adjust the timing of surgery accordingly. If they have hay fever, we don't electively perform surgery when they're symptomatic. If they have symptoms and signs of dysphonia premenstrualis, we operate mid-cycle. And we make sure that we select times when patients can and will comply with preoperative and postoperative voice therapy, which is so important to good results. Endoscopic voice surgery we usually think of as direct laryngoscopy, which we will talk about mostly today, but almost anything that we can do in the operating room endoscopically, we also can do in the office. That's not the primary topic of today's discussion, but we are doing more and more in-office surgery. There are instruments that have been designed and are available that allow precise resection of laryngeal masses, even laryngeal dilation. So many of the things that we avoided doing in the office because of lack of precision, we can do better than we could a couple of decades ago. Usually we do such surgery with an assistant and a flexible laryngoscope, but indirect laryngeal surgery has been around for a long time, a lot longer than I have. And if we are working without an assistant, we can use the patient as an assistant and still have a hand to hold a mirror or a telescope and another hand to hold an instrument. So it doesn't necessarily require an extensive team and somebody else to drive a flexible laryngoscope. There is an option for in-office surgery almost anywhere. But most of what we will discuss today is direct laryngoscopy. As with any surgery, exposure is key. We place laryngoscopes and guide them toward the ceiling so that we don't torque and put pressure on the teeth, as everyone here knows. Stability also is important. Probably the most common error I see as I travel and watch people, not anybody in this audience, but others operate, is lack of stabilization of elbows and hands. If we were doing ear surgery and someone a resident, for example, trying to do a stapedectomy without arm stabilization, we would take the case away. But people still do that in the larynx. The hands also benefit from stabilization. Hands against the body, instruments against the laryngoscope. And for those instrument sets, such as mine and Bob Ossoff's, that have removable handles that go on straight handpieces, those handles were designed not just to allow us to turn an angled instrument anywhere we want it through 360 degrees, but also to allow us to customize the length of those instruments. So if we're operating on a 7-foot basketball player or a 5-foot ice skater, we can customize the instrument in a second to be the right length for each individual patient undergoing surgery, so we can stabilize a finger against the laryngoscope if we want to. There are many good laryngoscopes on the market. I have a slight bias, which is why I designed this. The glottis is triangular. I prefer a triangular shaped laryngoscope and one with a little lift. We have all had to torque forward and put a little pressure on the teeth, trying to see a difficult anterior commissure exposure. This instrument has a built-in lift to do that, but I operated for decades with Dito instruments, Yako instruments, and others, and I think we can do excellent surgery with any laryngoscope with which we are comfortable. However, the microscope gives us a fairly limited view. This is with a 10mm 0-degree telescope, and this is the same lesion with a 70-degree telescope. I fairly routinely map lesions. This is the ventricle, so we can see if they involve 1, 2, or all 3/3 of the vibratory margin, and can map and limit surgery accordingly. And we can see if there are other hidden lesions or vessels that need to be addressed. I also find contact endoscopy helpful under selected circumstances. In the operating room, we also can do anything under local anesthesia. I use local suspension anesthesia occasionally. I use it virtually always for arytenoid dislocations, not commonly for other things, but we can do anything endoscopically under local, but we usually operate under general anesthesia, partly because the paralysis keeps the vocal folds still and helps precision. Also, often the patients are more comfortable. There is controversy regarding use of laser and cold instruments. I believe that in excellent hands, we can get comparable results with either. The carbon dioxide laser has been the standard laser over the years. We now use lots of angiolytic lasers. We'll talk about them in a moment. The main advantage of laser surgery is excellent hemostasis. The main disadvantage is the increased risk of thermal injury. That is a disadvantage that we don't have with cold instruments. Deciding what instrument we use starts with deciding what we're operating on. This is a picture from a book, not one of mine, that's labeled nodules. Frank Netter makes the same error. We can all see that this is not a nodule. This is a post-hemorrhagic mass with a contralateral reactive mass. Nodules usually get better without surgery. If we call every bump on the vocal fold a nodule, we will think our speech language pathologists or phoniatrists are not as good as they should be, or that those of us who claim a 90% resolution rate are not being accurate with our data, but we are. Those data are predicated on an accurate diagnosis. While nodules more often than not resolve or become asymptomatic without surgery, polyps, neoplasms, and other lesions, such as bronchitis edema when we need to operate it, neoplasms, papillomas, webs, generally require surgical intervention. The primary guiding principle of surgical intervention is to avoid scar that has the epithelium stick to the underlying layers, the vocal ligament. We want to continue having a freely moving mucosal wave. So everything that we talk about in modern surgical techniques is directed toward that end. This is a picture of a microflap. So far as I know, I introduced this concept. It was published first in 1982. It was my brainchild. I tell you that so that you will believe me when I tell you that it was wrong. It still has some places, but not for resection of benign lesions. The thinking behind this came to me from my plastic surgical training from Chuck Krause. We found that when we stripped off mucosa, we had the contralateral vocal fold striking fibroblast-bearing layers. We thought that that made trauma and increased scars. So the idea behind the microflap was to preserve the epithelium, remove lesions submucosally, and replace the epithelium as a biological dressing. And in most cases, we got better results, but not all. In some cases, we got stiffness far beyond the limits of the original lesion. Then Steve Gray discovered the basement membrane. We learned about the extracellular matrix and healing, and we realized that elevating a microflap isn't just elevating a flap, it is ripping to shreds elegant architecture that some patients will tolerate and some patients will not. Hence, the refinement of the introduction of the mini microflap. This is the surgical technique that we use still. It involves an incision at the border of normal and abnormal tissue. An instrument, I prefer a scissors, is placed against the inside of the lesion toward the glottis and spread, just as we would with a Metzenbaum scissors, allowing the residual superficial lamina propria to drop away, and we can then stabilize the lesion with heart-shaped forceps and use the inside as a guide and resect such lesions without disturbing surrounding or subjacent tissue, as follows.
This professional singer had persistent symptoms despite having plateaued in excellent voice therapy. Consequently, the patient elected to proceed with surgery. The 0-degree telescope shows a right vocal fold cyst and left reactive indentation. The 70-degree telescope illustrates the lesions on the vertical surface even better. This lesion is excised with an incision at the junction of normal and abnormal tissue using a Sataloff microknife. A straight scissors is used for blunt dissection and is leaned against the medial surface. Anterior and posterior limits of dissection are established with the scissors to prevent accidental extension. The lesion is stabilized with a heart-shaped forceps and excised with a curved scissor. This lesion involves the mucosa too intimately to permit submucosal resection. Following resection, Decatron is injected into the area of surgery and into the contralateral vocal fold.
Now, such lesions can also be removed with a laser. The most common error that I see when I travel in people using lasers is to aim the center of the laser beam in the same location at which we would make an incision with a knife. The laser beam should be aimed in the lesion itself so that the edge of the zone of destruction is still medial to the vocal ligament. We lose specimen when we do that. Not all of it necessarily, but we lose some pathology. If we aim the laser beam on the edge of the epithelium, then even with today's narrow beams, it is possible to create thermal injury and scar. But in the hands of an excellent laser surgeon, very good results can be obtained. In my opinion, You can't be an excellent laser surgeon without being an excellent cold instrument surgeon. I almost never use the laser on the vibratory margin. Part of the reason for that is that I'm in a teaching institution. I let my residents and fellows do many of these procedures. If a resident has a scissors in the wrong place and is about to close it, I can say stop. If the resident is using a laser, especially with a microslad, moving the joystick and goes in the wrong place, even for a split second, the damage is done. We used to use lasers, CO2 lasers, and more recently, angiolytic lasers to treat so-called feeding vessels. For several years, I have been looking at these feeding vessels with a contact endoscope. It turns out that the vast majority are not feeding vessels, they're draining vessels. When you look at the corpuscles, they are flowing away from the mass rather than toward the vibratory margin. So if they are draining the pathologic area, it seems to me to make less sense to ablate them than if they are feeding the area. We need evidence and data, but I stopped treating these vessels if they are draining rather than feeding vessels. Everybody eventually will be switching to the blue laser because KTP laser has been stopped. It's no longer being produced. I have found the blue laser to be surprisingly precise. It's good for ectasias, for vessels, and for limited cutting. It will not work for a large supraglottic tumor. It's no substitute for a CO2 laser at 10 or 15 watts continuous, but for small lesions and for posterior glottic stenosis and subglottic stenosis radial incisions, it creates very little char. It appears to create less thermal injury, and it's quite precise. It is not the only technique for dealing with vessels that either bleed repeatedly or that engorge on phonation and create dysphonia, particularly in singers. The procedure for vessel resection is one that I developed out of desperation in the operating room more than 30 years ago when all we had was CO2 lasers. My index case was a Broadway star, a legit star. I can't say anything that might give her identity away, but let's just say she sang leads in things like Phantom and Les Miserables. So she was a high soprano. She had screamed at her boyfriend in the car, ruptured a blood vessel on the edge of her vocal fold, and had a large varicosity associated with that post-hemorrhagic mass. I touched it with a CO2 laser, it bled. I touched it again, it bled. I was sure I was going to end up scarring her. So in desperation, I took a needle driver and bent a 30 gauge collagen needle, used the tip of the needle to make an incision along the vessel, slid the instrument underneath the vessel and used it like a right angle and elevated as you would a jugular vein, resected it at both ends, and she was asymptomatic and back on Broadway in 8 weeks. So I have been using that for selected lesions ever since that time. If you use a CO2 laser, there are a couple of bad things that can happen. We used to use them defocused. If you're too gentle, in a few months, it looks like you didn't do anything and the vessel's back. And if you're too aggressive, you can end up scarring the tissue underneath the vessel. And if it's this close to the vibratory margin, that can be problematic. Angiolytic lasers work much better, but unless they are used technically correctly and we understand the melanin absorption characteristics, they also can damage tissue. If you resect a vessel, it's gone. They don't come back. You can make your own instrument, as I just described, or there is an instrument that's called a vessel knife that's blunt on the bottom and has a sharp point. And this is the technique.
This successful professional singer complained of voice fatigue, decreased control, and a heavy feeling to her voice. Examination showed prominent vasculature However, the most important observation was that after she had used her voice for a while, the blood vessels on her vocal folds dilated and were raised rather than flat. At that point, her symptoms occurred. She underwent excision of the abnormal vocal fold vasculature as illustrated in this case, and her symptoms were relieved promptly and permanently. Symptomatic varicosities can be treated with laser or excision. A 70-degree telescope should be used to be certain that there are no other vascular abnormalities. For excision, an epithelial incision is made with the point of a Sataloff vascular knife. The angle of the instrument is used pressed against the vocal fold to elevate the vessel. The vessel is then stabilized gently with an alligator forceps and resected posteriorly and anteriorly. Bleeding usually stops spontaneously, but coagulation with a laser can be used.
Incidentally, I will mention in passing that I am proud of the fact that the surgery done in some of these cases is being done by my fellows or residents. While this is challenging surgery, the residents start with me in their second year. They're talented, they have steady hands. There's very little that I'm not comfortable letting them do because there's not much they can do that I can't fix. Klein-Sasser described the surgery for symptomatic Reinke's edema. Our first issue with Reinke's edema is making sure that the patients want their voices improved. 3-pack a day, female attorneys who like being mistaken for men over the phone and come to see us to make sure they don't have cancer will not be happy patients if we get rid of their Reinke's edema and give them a nice, normal, feminine soprano voice. So unless they do not like their voice or have an airway problem, this condition doesn't necessarily require surgery. Now, Oscar Klein-Sasser came up with the idea of making an incision, suctioning out the Reinke's edema, and then redraping the mucosa, perhaps conservatively resecting a little redundant mucosa. And this operation works really well in drawings. In the operating room, sometimes yes and sometimes no. Everybody in this audience has been there. Sometimes you put in a suction and nothing happens, and you end up removing the excess tissue in Reinke space with a cup. Some people use a laser. Any of those activities, including suction, can traumatize and cause inflammation of the residual epithelium, which is already floppy. Now, what I'm about to say is controversial and it's opinion. I almost never operate on both sides at the same time. Jim Gould and I both saw the worst webs that we ever saw, referred to us from good laryngologists whom we trust, who told us that they had done Klein-Sasser's procedure on both sides, not touched the epithelium. And because I am sure of the inflammation caused by the trauma and the redundancy, they ended up with almost complete musculomembranous webs. So he started and I started at the same time, only doing one side. That is not the only reason that I only do one side. The other is patients who have Reinke's edema have a low voice, but low phonation threshold pressures and easy phonation. If we take a little bit too much tissue and traumatize this area and get scar, get a hypodynamic or adynamic vocal fold, and we have Reinke's edema on the other side, the patients do fine. If we have scar on both sides, their phonation threshold pressures are up, phonation becomes effortful, and they are worse off than they were before we operated upon them. So I do the worst side, let it heal and make sure there's a mucosal wave, and then plan to go back and do the other side. Jim Gould went his whole career after he started doing this without ever having a patient elect to have the second side done. And more than 90% of my patients are happy after having one side done and leave the other side because they're happy with that voice compromise between what they have been used to and normal. Webs are a plague for all of us. Since this is such a distinguished audience, I couldn't resist throwing in a couple of new things, since I'm sure most of you already know everything I've discussed so far. The standard treatment for anterior glottic webs is placement of a stent or keel. It can be done internally. It can be passed through the skin and stabilized. This is an old technique that I introduced, and I show it because this is the index case. I published it, and my technique was wrong. There's still a place for this, but in case anybody goes and looks this up and tries to duplicate it, don't. I made a foolish mistake. This is a patient who had recurrent respiratory papillomatosis, exceedingly aggressive. She needed surgery every couple of months. She was a board member of international corporations, used her voice extensively. She had one side done and came back with a total musculomembranous web. Because her papilloma was so aggressive, and this was a good 30 years ago, I was afraid to run stitches through her neck and tie them on buttons externally to create a suture tract and potentially have papillomas grow out into her neck and end up with extralaryngeal papilloma. This is a piece of 0.02-inch reinforced silastic. This is Proline, and the sutures run lateral to the vocalis muscle. So this is sutured entirely internally within the larynx. And I put this in and figured I'd watch and wait a few weeks until the other vocal fold healed. The foolish mistake was tying the knots in the glottis in the easy place. This knot continued to cause ulceration in the contralateral vocal fold. So the technique is pretty good. The technique works, but the knots have to be tied in the ventricle. So there's just suture here and nothing that will traumatize the other vocal fold. However, almost anything that I've ever done commonly leaves us with a little bit of blunting at the anterior commissure. This is a new idea. It is not available commercially, but we can make it ourselves. I mentioned Boston Medical, which was going to make this prosthesis. After they got purchased by a European company, those arrangements stopped. So right now we're negotiating to have this made available commercially, but you'll get the idea.
Anterior glottic webs are always a challenge for laryngologists. In order to address the problem of recurrent anterior blunting, a prosthesis has been designed and will be presented in this video. This prosthesis was designed by me, Dr. Sataloff, and I do have an interest, which I am acknowledging here, in the prosthesis, which is being manufactured by Boston Medical. The prosthesis that will be shown here is a prototype. The final prosthesis is of a stronger material that does not fall apart when a needle is placed through it. The final prosthesis also will be supplied with the stitch in place and with an inserter that makes it much easier to position than the prosthesis illustrated in this video. However, the case is presented to show the principle and early results. This patient has undergone more than 50 surgical procedures for recurrent respiratory papillomatosis. In such patients, glottic webs are common. They present several problems. One is a reluctance on the part of the surgeon to place sutures from the larynx externally because of concerns about creating a tract for spread of papilloma. Hence, internal stenting has been described in the past. This new procedure improves, we believe, the outcomes. Palpation confirmed the presence of a web. An incision is made anteriorly where the anterior commissure should be, preserving the posterior portion of the web. A through-and-through incision is made, and a suture is passed. The suture also is passed through the center of the prosthesis. This is a prototype prosthesis. It splits slightly during the procedure. The final material is firmer and does not split. The suture is also embedded within it, and it comes with an inserter. The prosthesis is tied around the residual web and stabilized. In 3 weeks, it is removed. At that time, the suture is divided, and the prosthesis is taken out. An anterior commissure has been created, and the adjacent areas are mucosalized. Essentially, this has created a mucosal bridge in place of a web. Scar tissue is removed, and the edges are made reasonably straight, if somewhat scarred. Decadron is injected. Because the anterior portions of the vocal fold are mucosalized, no further stenting is required. This video shows the appearance of the vocal folds and persistence of the sharp anterior commissure. This examination was performed approximately 6 months following surgery.
I have done several of these now. I also have used the same principle for supraglottic webs. It works well. Essentially, you make a small incision and use the web itself to hold the prosthesis forward, so the sharp front border of the web is pushed against where you want the anterior commissure to be. And I've been happy with the results. I'm continuing to use it. Now, this is brand new. I would suspect probably none of you has seen this before because I just came up with this last year. This is a pretty sick man with posterior laryngeal stenosis. He had multiple intubations and he had multiple attempts at repair, all of which, as they often do, failed. So this is after multiple attempts. This is he's had lasers, he's had mitomycin C, 5-fluorouracil, lots of things. But you can see he's still pretty tight and he is active, and that's not good enough. So this is the new concept. This is anterior, this is posterior. It is the same principle as the anterior web we just discussed. This is a channel. I made this one with a CO2 laser. There's a lot less char if you do it with a blue laser, which works fine for this. And then passed through that posterior channel, initially 0.02 inch silastic. Again, we've changed from a solid web to having created a bridge with a mucosalized posterior area. I actually have come up with a design, this is also currently patent pending, that'll make this easier. It comes with a suture embedded in it, so you can just slip it in and tie it once you've opened up the posterior channel. This is the same patient 4 months later. Not perfect, but he can run, he can bike, he can do pretty much whatever he wants, and this is a lot more open than we ever got him before, and he's close to a year now without any recurrence. So I think that the concept has merit. We need more experience. There is a place for all instruments when we're dealing with recurrent respiratory papillomatosis, but I make a distinction. We all, or most of us, grew up with very aggressive recurrent juvenile respiratory papillomatosis. The same kids trained generations of residents. Adult onset papilloma that we've seen over the last few decades I believe is biologically different in most cases. It's often considerably less aggressive. Generally, especially if it's limited, I do submucosal dissection, hydrodissection. I do it with cidofovir on the basis of no evidence at all. You certainly could do it with saline or saline and epinephrine or whatever you want, but I use cidofovir on the fantasy that it's a little more protective, and resect limited adult onset papillomas with a microflap as if they were carcinomas in situ. I do not like using lasers for these lesions. And I will tell you why. Most of the people on any quaternary or tertiary care laryngology service have seen patients referred with papilloma in the muscle, sometimes outside the larynx. That is iatrogenic disease. The surgeon did that. This is epithelial disease. If we use a laser, even on the superior surface, especially a CO2 laser, we stand a fair likelihood of creating some holes in the muscle. It's like planting tulips. We are breaking a barrier and allowing the papilloma to get into deeper layers that it would not access without our help. So I very rarely use it except occasionally on the false focal fold, although it certainly would be more convenient. We use a needle to hydrodissect, elevate, and resect. None of us should fool ourselves into thinking that we're actually curing these, but we can often get very long-term control. I also use cidofovir regularly once the diagnosis is confirmed. Also, just as a bias, I retype these, do viral typing repeatedly when I have to do repeated resections. And I have reported this. We have had some patients who converted from low risk to high risk after having gone through a few years of having type 6 and 11, and then turned up with type 16 and 18. And when that happens, I follow them more closely and more aggressively. I like to know if they have high risk disease, but for sure they can change. That's one of the reasons I think Gardasil has value. It doesn't help all that much, I don't think, with papillomas with viral types already infecting a patient, but it does help protect against infection with new viral types. That also is opinion and requires a lot more research and good evidence. I also do not hesitate to use powered instruments. I was very reluctant about the laryngeal shaver. It didn't seem to me that it should be precise, but if you use a 3.5 millimeter laryngeal shaver at 500 RPM, it can be surprisingly precise. I use it mostly in patients that I know I am never going to cure, in whom I'm trying to get control to optimize voice, at least temporarily. Now, there are some conditions, each of which would be worth an hour lecture, which we're mostly not going to cover today. I'm not going to talk about cancer at all, except to say that for a T1 lesion on the vibratory margin, I do not know which will create a long-term better voice, radiation or resection. In the first 6 months, I'm sure it's radiation. At 5 years, I'm not at all sure. We really need a good multi-institutional, ideally multinational controlled study to answer that question. But I can tell you that if I had one right now, I would have it resected, not radiated. SCAR is an interesting and challenging problem, one of my favorite vocal fold dysfunctions. It has been treated with steroid injections, raising flaps, lowering flaps, all sorts of things for decades. About 4 or 5 years ago now, I stopped using steroids and started using 5-fluorouracil. It is discussed and researched extensively in the plastic surgery literature for treatment of scar. I figured scar is scar. I used the mixture that was used in the plastics literature. It contains triamcinolone. I don't like triamcinolone. I use dexamethasone when I'm doing steroid injections because triamcinolone is a suspension and it can have white material come out of suspension and create a leukoplakic-like lesion that can last for up to 8 months and create a stiff vocal fold. However, since this was such a novel use, I figured I was better off using the same mixture for which there was existing literature. Also, this uses a mixture with 4.5 milliliters of 5-FU and 0.5 milliliter of triamcinolone. So the concentration is so low that there's never been a problem. We are now finalizing the paper on this. I have been astonished at the results. I have to tell you, I didn't expect them to be this good. We have mucosal waves in people in whom I never got mucosal waves with repeated steroid injections. As we all know, Shigeru Hirano has done some very interesting work with growth factors. There is a commercially available product called AmnioFix, made from amniotic materials, that has most of the growth factors that he used. You can also create it with platelet-rich plasma, which can give you growth factors, and you have some growth factors with autologous fat. I've only been using growth factors in humans for about 9 months, so I'm not ready to make a comment yet. I need longer observation. I can tell you that short term, it doesn't seem to be working as well as the 5-FU, but we all need to be thinking outside the box for vibratory margin scar. Now, for severe vibratory margin scar, I guess probably 20 or 30 years ago, I introduced the concept of autologous fat implantation, not injection. This operation requires a little explanation. When I originally, first of all, my original thinking was all wrong. My thought was you had a stiff edge, you had a wave on the other side. When the peak of the wave met the stiff wall, the valley of the wave didn't, so you had breathiness and irregularity. My plan was to make a soft edge so the sides could interdigitate. I tried elevating and putting fat in. You can't suture it. When you tie the suture, the holes that come from the tying of the suture are big enough to let the fat extrude. I woke up at 3 o'clock in the morning one day and knew how to do this. The trick is to create an access tunnel, a small incision, and elevate only in this area. The rest of the superior surface remains undisturbed. You then insert a right angle instrument, usually a right angle ball dissector. I do have an instrument called a flap knife that has a sharp edge on the bottom. So in really bad cases, you can put a 90-degree instrument in and cut straight down. I used to use a scissors and it tended to tear the access flap. You then fill the pocket that you've created, and the pocket goes fairly far vertically. So you're creating a whole contact area. You fill the pocket with fat. I tried to do it freehand with fat resected. It was always lumpy. I harvest this with a large 1 centimeter liposuction cannula and put it in with a pruning syringe. Now, here's the trick. The more fat you put in, the more the epithelium is pulled away. And the more it pulls away, the more firmly this tunnel closes. It's a self-closing trap door. So you will see how this works.
This patient had a 10-year history of severe dysphonia. She was found to have profound scar bilaterally with virtually no normal mucosal wave. No etiology was identified, and she had had a good voice prior to the onset. An incision is made laterally, and a blunt ball dissector is used to elevate a narrow access tunnel. The ball dissector is fed through the access tunnel and used to elevate a pocket along the vibratory margin in the area of scar. This pocket is then filled with fat using a Bruning syringe to deliver the fat. The access tunnel closes automatically as the fat is placed.
So for this one, I wanted to show you some patient results. They're not perfect. This is that patient, the Albanian lady. Pre-op.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
In Albanian?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Again? Again?
Gezward Italian, Gezward Italian, Gezward Italian.
Okay, good. Cough. Again?
And this is post-op.
Happy birthday to you. Happy birthday to you.
Again?
So that was about a year post-op. By no stretch of the imagination perfect, but for somebody with essentially bilateral adynamic vocal folds, she was good enough that people stopped asking her if she was sick. She could carry on a conversation in a restaurant. So there is a place for the autologous lipo-injection or lipo-implantation. McCallion, Lowry, and I introduced the concept of autologous lipo-injection in the 80s. The fat goes into the same place in which we used to put Teflon. The usual error in doing fat injections is under injection. We need to have at least a 40% overcorrection. My indicator is when the resident on call asks me if I wouldn't like a little steroid, then I do a few more clicks and we're done. So that's what a fat injection should look like at the end. This is a trick. I don't know if anybody else does this. I haven't heard anybody talk about it. But when I do a fat injection or inject any other material, I really don't want my anesthesiologist milking it out like toothpaste. So I do the extubation deep with the laryngoscope in place, and the laryngoscope holds the tube posteriorly.
When the surgeon extubates the patient with the laryngoscope in position, the laryngoscope holds the endotracheal tube posteriorly, preventing trauma to the musculomembranous portions of the vocal folds.
So that way I can make sure that my fat isn't displaced, and I can also make sure the balloon is completely deflated. I'm not going to talk about arytenoid dislocation today because I would rather spend a little time showing you a completely new concept. Arytenoid dislocations absolutely occur. The techniques are different for posterior dislocation compared with anterior dislocation. The only thing worth mentioning in an anterior dislocation is that any manipulation can't be done below the vocal process. There's an embryologic fusion plane, as you all know, between the vocal process and the body of the arytenoid. It's a fracture line waiting to happen. This involves bimanual technique and an instrument that's a Hollinger laryngoscope placed over the entire face of the arytenoid and used to bring it back into place, usually in conjunction with botulinum toxin. Now, this is another completely new idea, so I thought I would share it with you.
This 15-year-old had been intubated at birth and had had a weak cry noted at the time of extubation. Her voice had always been abnormal. She had a dislocated, lateralized arytenoid with the vocal process at an inappropriate height. Arytenoid reduction was attempted and failed. The arytenoid could not be moved. An external approach to perform arytenoid adduction rotation or arytenoidopexy also failed because the arytenoid was found to have been comminuted. When it was cut free, the tissue was so friable that solid suturing to the appropriate portion on the cricoid cartilage was not possible. Hence, vocal fold replantation was devised. It involves endoscopically incising the scarred vocal fold tissue to completely mobilize and medialize the true vocal fold, moving the vocal process and a bit of adjacent residual arytenoid cartilage, and suturing that cartilage to the midline of the cricoid cartilage at the proper height. Palpation confirms complete immobility and fixation of the right arytenoid, and the vocal folds are at different heights. A suture is placed coming from posteriorly into the larynx through the cricoid cartilage. Incisions are made and soft tissue dissection is utilized to mobilize the right vocal fold, allowing it to be brought to the midline and the appropriate height, and then reimplanted directly, sutured to the cricoid cartilage.
So that actually worked. She ended up with a vocal fold near the midline, had a little injection medialization, and a more or less normal voice. There are lots of other interesting things about which we could speak: pitch modification for transgender, SD, lots of other things. There is not good evidence on postoperative management, either with steroids or voice rest. I don't use steroids except intraoperatively in most cases, or antibiotics. I do use voice rest until the epithelium has healed, usually sometime between 3 days and a week. In professional voice users, while we are all reluctant, we need to be willing and not deny the people who need perfection most just because of our concerns about making them worse. Yes, we don't want to make them worse, but if they are unable to make a living, we need to make them better. It brings great joy to life.
I was on tour for a week in San Francisco with my a cappella group, and I felt really vocally fatigued for the entire time. But because we were performing and we were getting paid to do like a lot of gigs while we were there, I still had to go on stage and just sort of sing through it. I went back to my voice teacher and was having so many issues just singing in my normal range. It had been totally cut. I went from like this to this, essentially.
Arpeggio.
They did the whole scope. They did a camera down the throat and found the lump there. It was the first time I had actually seen it. There was a video camera down my throat, and I could see it over the guy's shoulder. It was this huge lump on my vocal cords. It was like one of the scariest things I've seen.
Okay. Now, as you're saying it as a statement, can we gonna make that feeling of open stay there? 5, 6, pick up sticks. Keep the sound here, sticks. It's hard. It's a hard one.
Yeah.
Keep it in your mouth.
5, 6, pick up sticks.
Better. That's better.
Yeah. It's very easy to listen to her instructions and to accomplish them. It's clearly coming from someone who knows a lot about the voice and how it functions.
Risks of surgery we went over before: bleeding, infection, swelling, scarring, recurrence. The mass can come back.
Right.
Doesn't usually happen, but if I do everything perfectly and you do everything perfectly, you can still have some scar you already do. Remember, the problem with that is a healing problem. If you make an incision on the belly and do an appendix on 100 people, 1 or 2 of them will get a big ugly scar. We hope you won't be one of those, because if you get a big ugly scar in your voice box, your voice can be permanently hoarse. It can be worse than it was.
All right. This is looking at the mass with a 70-degree laryngeal telescope. You're now looking, there's the front of the vocal folds, and that there's some abnormal blood vessels that we will probably leave alone further back.
Take an incision along the superior surface of this mass at its junction with normal tissue. Straight. We use the scissors to bluntly dissect. Get the posterior limit of the mass. The scissors to revert the lesion a little bit. Perfect. This is Decadron. It is a corticosteroid that we're using not just for anti-inflammatory purposes, but to try and loosen up some of the scar. Suction, please, and this is a topical anesthetic, so it will decrease any irritation he might feel as he awakens. We're done.
How are you? You're able to come off of voice rest. How do you feel? You're allowed to talk. Yeah, let me hear your voice.
I'm so scared to speak.
I could tell that. I could tell that downstairs.
Today is the first time I've spoken anything in over a week. And surprisingly, it feels so much better than before the surgery. Like, there's just no weight on my cords. Even though I don't necessarily feel hoarse, it sounds totally different to me, but it feels much healthier.
Relax. For a month post-op, you look just fine. Great. Time to start doing some singing work.
Too late to run for cover. She's much too close for comfort now.
Good.
Be soft.
After singing the solo a few times, it just came out really naturally and easily, and then other parts in the music that I thought were difficult even before I knew I had the polyp are so much easier to me now.
Be firm, be fair, be absolutely sure, beware.
It just feels so much smoother, and I guess I have the sensation that I'm singing well, which I haven't had for a really long time, and that's back again, and it's really exciting to have it back.
I thank you all for your attention. Hopefully, we will have the pleasure of seeing you at the Voice Foundation meetings in Philadelphia soon and often. And I will be available for questions. Thank you again for inviting me to spend this time with you.